because if you have PCOS or if you're on an oral contraceptive or any hormonal contraceptive, lots of things can skew hormonal profiles to make you think that you have something that you don't. Hello, good morning, where you are.
Hello, how are you?
I'm doing well, thank you. Thank you for chatting with me today.
Oh, it's been a bit of a pleasure, but also like trying to get it right with you and the timing and everything. So it's so exciting to have a chat with you today.
Absolutely, likewise.
Do you hear me perfectly fine? No problems?
Yes, I do. And if you don't hear me well, or if there's too much of a lag, I know if you're further around the world, the lag is slightly more, which is okay. But I have a whole host of microphones and earbuds if I need them.
No, all good. I hear you perfectly. Now, I've got a lot of questions for you, so I want to jump right in. I know we did an IG Live quite a while ago, and I think we did cover quite a few questions, but I think I'm going to take some of those to use a recap. Maybe there's some updates about it. We will dig into all the things that you have on your channel that I find super interesting and some new updates. How are you feeling about the plan?
I think that sounds great.
Well, Kyle, I would really love to get an introduction about who you are and why you do what you do before we move any further.
For sure. So for those who don't know, I'm Dr. Kyle Gillett. I'm an MD, a medical doctor, and I'm board certified in family medicine and obesity medicine. But my practice consists of what I'd call individualized medicine. This is evidence-based care and shared decision-making with the patient. So I'd like to explain all of the benefits and risks of every intervention, whether it's lifestyle, medication, or supplement, with all the patients that I have. This does take some time to do, but I think that it's what preventive medicine and primary care should be. I do my best to meet the demand for questions about hormones, fertility, and body composition, because as people who listen to you realize, there's a lot of misconceptions that people can benefit from if people professionally and nicely explain why there are misconceptions and actionable items to help improve those.
Now, tell me something about you, Kyle. And I guess this is just trying to go a little bit deeper. Why you do what you do? What made you decide to be in the medical field? What made you just choose the path you've chosen?
Yeah, I'm from Kansas City, Kansas. I've grown up here essentially all my life. All of my family lives here. My father's also a family medicine doctor, and like me, he practiced, he still practices full spectrum medicine, taking care of the body, the mind, and the soul. We've both delivered, a couple hundred babies, if not more, him more so than me. But, when I was growing up, I was homeschooled and I was heavily involved in the outdoors. I enjoyed science and biology, and I believe in God. I'm a Christian. But I also realize at the end of the day, we are organic machines, and it makes sense to take care of the machine that we have. So it just felt like the most fulfilling career choice that I could make. I'm particularly interested in what I do. And I always say that I'm just doing what my hobby is. I happen to make enough money doing it to feed my family. I'm married. I have two kids, and I live on a farm. I have chickens, dogs. I'd love to have a cow someday. But yeah, I'm probably what you would consider more or less your stereotypical Kansan family doctor who happens to love medicine, and I like to learn as much as I possibly can about it.
I love that. Now, I want to ask several questions that are coming from a lot of people that aren't really sure about the importance of blood work and how this can truly be meaningful, especially when you're not know, when you don't know how to interpret these specific results, what is important to know about blood work per se? What information does it give us?
Mhm.
And what are some of the major ones that we should be paying attention to? And then I guess I'll ask a little bit more in detail when we're looking for specific markers, especially when we're looking for thyroid function or when we're looking for sexual function for women. How do we identify certain adjustments or certain changes as we age? Let's
Mhm.
say perimenopause, menopause. How do we really know what's happening if they are so volatile and fluctuating depending on when you're measuring these hormones? So I guess it's a very
Yep.
broad question coming from the blood work and then sort of narrow it down to specific blood work.
Yeah, that's a great question. To answer the question about the part about the blood work is, and sometimes I give presentations or whatnot, and I find a reason to include this slide, and it has the meme of the guy is sweating and he's deciding should he push button 1 or should he push button 2, and button 1 is pretend that hormones don't exist, and then button 2 is admit hormones exist. You have to check the level and then you have to interpret the level. So, obviously hormones exist. Another one of my patients famously commented her OBGYN or whatnot did not want to test her testosterone, probably because he or she didn't know how to interpret it. And they said, well, no, this is not a female hormone. And she asked, then why is it in female bodies? Which is, I thought was brilliant. But the takeaways from that is, yes, depending on what your goal is, there's different times of the cycle to check them. So if you're looking at ovarian reserve, day 3 or day 4 is a great time to get your FSH to LH ratio, your antral follicle count. But in general, you should have these ordered with the help of an expert, because if you have PCOS or if you're on an oral contraceptive or any hormonal contraceptive, lots of things can skew hormonal profiles to make you think that you have something that you don't. So with that in mind, if you're looking for a baseline, then often when you feel best is a great time to check it. A lot of times that's days 12 to 15, or whenever you have an LH spike. It's reasonable to check hormones at that time. Often you have a bit of a testosterone spike during that time as well. But anytime you check a testosterone, and this is for both males and females, but is especially important in females, anybody who knows me knows my first question. So just like when someone says, "Hey, I weigh this much," or this is the weight I want to get to," my first question: what does your body composition look like? What is your DEXA, etc. My first question for hormones in females is, what is the SHBG? So SHBG is sex hormone binding globulin. I think Dutch test is now finally added. I always joke that I'm never going to get a Dutch test sponsorship, but I think that I've chatted about how essential serum SHBG is, even for interpreting salivary and urinary hormone tests, that they're kind of finally starting to add them. So I feel somewhat validated for that. But anyway, that sex hormone binding globulin binds all androgens like testosterone and estrogen. So if you have low testosterone of 15, and let's say you're a female, regardless of when you check it in the cycle, maybe your early follicular phase, the very first part of the cycle. So maybe that's a little bit lower. But let's say you're two women, they're both mid-cycle. They both have a total testosterone of 15, and people argue about whether this is high or low. If her SHBG is 15, then that is a normal to high testosterone. If her SHBG is 150, then that is a low testosterone. So you cannot interpret total testosterone levels in females without a SHBG. And testosterone is so low in females that even with equilibrium dialysis, free testosterone assays are not very accurate. So all that jargon that I just said, I'll summarize it. Free testosterone, not accurate. Estradiol immunoassay, which is the normal estradiol it's ordered. If you don't order sensitive, not accurate under 50. So if you're postmenopausal, get a sensitive estradiol. Or if you're male, get a sensitive estradiol in general. And then check an SHBG. I'll add one more, check a DHEA sulfate to get a general idea of adrenal androgen production.
So with that said, would you say when you want to know more about like your estrogen levels, like even progesterone, for just for the sake of knowing whether they are particularly working well or fluctuating right within your menstrual cycle, let's say in just normal adult women before menopause, when would you say that it would be the accurate time to measure it, to know exactly whether there is actual good function of your ovaries and the cycle is actually coming to a good rhythm? Because we know that sometimes you'll get clients or patients that have been chronically dieting and have low energy availability. There could be some hypothalamic amenorrhea present. Yep. Or if you have a client with PCOS or any sort of cycle dysfunction, how do you know, perhaps not so much as a way to diagnose it, but you as a practitioner, and maybe for anyone who is working with that client, is able to help identify and help the client to do or make informed decisions when it comes to treatment, when it comes to lifestyle, or any sort of modification that they may need to do when this presents?
Yeah, the way that you approach a patient, as you basically mentioned, is an individualized manner. So let's say they have a history of PCOS. They've probably met Rotterdam criteria in the past. And I've done specific podcasts, the Gillett Health podcast, just on PCOS and just on hypothalamic amenorrhea. And an entire population, HA or hypothalamic amenorrhea, which is generally where you have skipped cycles and also very low hormone levels, is very rare. But in the fitness community, it's actually quite common. And there's a lot of changes that are kind of unique. For example, one of the unique changes is for those with hypothalamic amenorrhea, they probably should avoid canola oil and also avoid too high of amounts of omega-3s. And they could benefit from consuming more fructose. As demonized as fructose is, that could help. So that's just an example of a niche individualized dietary only solution. You know, large groups of people argue about whether or not fructose should be loved by everybody, hated by everybody, or somewhere in between. But it really comes down to the individual, as most that are like very, like, you know, the more into nutrition you are, the more you know the right answer is always, it depends. So I'll do my best to not answer an it depends. Past that, I like to get what's called low tide and high tide labs. So labs kind of at the worst, whether it's symptom related or whether it is cycle related, and then labs at the best as well. So like, you know, assuming all the lifestyle factors are optimal in this time period. So for a good example for a bodybuilder is when they're in their general maintenance, maybe a touch of a surplus, complete off season, other life stressors are not influencing the limbic system, which heavily influences hypothalamic output. Labs then would be called low tide labs. The least damage is being done. Then you also want high tide labs. You know, that's when you're extremely stressed and your nutrient status is not great. That way you know what you can do with those lifestyle interventions and extrapolate from there.
Okay. And if I wanted just to check on clients that are just normal, let's say on their normal adult life, and you want to check their function for, is your cycle being okay? Do you have any sort of issue with estrogen or progesterone? Do you tend to check it around ovulation, around week 4, which is closer to the day 1 of the cycle? When is the best time to check for female hormones?
For progesterone, the best time is day 21 or after. Some females have what I'd consider a subclinical luteal phase defect, and nobody needs to remember that. But basically, the last part of the menstrual cycle, the luteal phase, you can have 2 parts of the luteal phase. And as progesterone increases, the withdrawing of the progesterone. So in luteal phase, progesterone spikes and then crash. The spiking and then crashing of progesterone causes what I call a progestogenic cascade, Some of these types of progesterone, after they're reduced, cross the blood-brain barrier and bind GABA, the same thing that Xanax or alcohol binds, or the same, not alcohol doesn't directly bind it, but point is the same thing that Xanax binds, and it can either activate it or inactivate it, depending on which form of progesterone. So there's a lot of variability. So the higher the spike and crash, the more likely that is to essentially flood the dam, if that makes sense. The progestrogens are cascading down the pools or the dams. So yeah, for that, you definitely want to check after day 21. In general, if your progesterone is above about 6, you've probably ovulated. And if it's above about 10, then it's extremely likely that you have, even if you missed an LH spike earlier. So LH is the hormone that comes from the pituitary in the brainstem and then goes to the ovary. And then FSH is another hormone. We call those gonadotropins for people that aren't as familiar. And then the term progestogen that I'm using, that would be like progesterone, 5-alpha progesterone, 5-alpha, 3-alpha progesterone. Those are progestogen neurosteroids, if people have heard of that. That's why a lot of people with premenstrual dysphoric disorder or PMS symptoms try various forms of progestin or things that kind of raise the height of the dam, if that makes sense. So that's progesterone. For estrogen, usually you'd want to check mid-cycle if you're trying to catch a peak, but luteal phase is also great for that. So if you're trying to see if you have enough estrogens and progestogens, then you want to check around day 21.
What would you consider is the biggest event for a cycle to happen? And whether with someone with early hypothalamic amenorrhea, you would get potentially symptoms of having PMS or having somehow ovulation or an ovulatory phase, but you don't actually see bleed regularly.
You don't regularly see a bleed. If there's no bleed whatsoever, or if it takes longer than 35 days, or if there's 9 or fewer menstrual periods per year, it's generally considered oligomenorrhea or not enough menstrual period, which can be due to many reasons. If there is very light spotting, especially if someone's pretty lean, then often it is related to kind of like the athlete's triad, low body fat, often iron deficiency. So that's pretty common if there's just very light cycles or spotting. About, a significant portion of females on hormonal contraception still have very light periods. Some of them will occasionally just bleed so little that they essentially don't notice it. So the way I think of the, estrogen and progesterone, estrogen is building the blocks in the Jenga tower. Progesterone, as it increases throughout the cycle, is kind of stabilizing the endometrium, if you will. When you remove the progesterone, the Jenga tower falls down. Like, it's not the progesterone that knocks it down, but if somebody is missing that progesterone spike, sometimes there's just like a little bit, and there's not enough to where you all of a sudden withdraw it, and then you have that endometrial shed. That's why, in general, if you go to the doctor, then a lot of times they'll do a trial of progesterone. So they'll prescribe something like medroxyprogesterone or some other progestogen for something like 5 to 10 days. And then as soon as they stop that, often if the blocks have been built up high enough, and if there's enough endometrium to shed, it will often shed.
Okay. Would you say that then the main event for all of this to happen and these hormones to actually go up and down would be reliant on ovulation, would be like the major event, like if there is an ovulation or not? That is what is going to depend the trigger of this cascade of hormones for progesterone to increase or not increase, or could be completely unrelated to your ovulation?
It can be unrelated to ovulation. They're closely correlated because gonadotropin spikes lead to production of estrogens, progestogens, and ovulation.
Okay. Because at the end of the day, when we think about the physiology of the hormones that are produced in your ovaries, and then like the actual egg may start producing specific signals and hormones that are going to tell your uterus, well, we're getting ready for pregnancy, like LH and like all of these signals that are going to trigger progesterone as well. If you are not releasing the egg, then how are we monitoring or managing the effects on progesterone and the production of LH and all of that?
Yeah, if you can still build up endometrium even if the egg has not been released, and you can still shed it, I suppose, if that makes sense. But yeah, another way to think about it is, you're preparing the home for the egg for any potential conception, and you wait several days for conception to occur. And if conception does not occur, the corpus luteum, so think of the germ cell line. Maybe this is a little bit too technical, but when you ovulate, part of it becomes the ova, part of it becomes essentially what looks like a cyst in the ovary. So sometimes if they do an ultrasound and you might be ovulating, they're like, oh, there's a cyst or a corpus luteum. If that kind of kicks in and kicks in extra hormone production, then it's more likely to implant. But once you're kind of in the late luteal phase, consider it more inevitable. That's why there's this huge debate on whether or not, for people without the history of preterm labor or recurrent miscarriages, what progesterone does during pregnancy. The short answer to that, by the way, if anybody happens to be wondering, is it's more to do with the ratio of estrogen to progesterone. So it is extremely common that I have very lean female patients who are early in pregnancy. They get their progesterone tested. They have no history of pregnancy loss, and they're told they have low progesterone. The pregnancy will not survive if they do not take high doses of progesterone because it's so low. But what really is just happening is that they run low estrogen because they're low body fat, and they probably have always been very sensitive to estrogen, and their ratio is very normal.
You mentioned something very interesting, and I do have a client she currently had a recent miscarriage, and she's actually been told that she needs to take progesterone. Would this have an impact on appetite, on cravings, on like even higher fluctuation of fluid between like I suppose your body actually having your normal daily fluctuations, but on top of that would be an additional, I guess, load coming from adding extra progesterone to it? When especially if you're someone who is trying to monitor pregnancy weight increases per week, and then you suddenly see a huge spike in weight, and then you're kind of like off charts, and you should be trying to get back on track.
Yeah, as you mentioned, very common to see fluid retention secondary to progesterone supplementation, including in pregnancy. And yeah, about 10 to 20% of women have a very dysphoric reaction. They feel almost depressed and very sluggish with progesterone, almost like some people feel more sluggish if they take Xanax, especially if it is a very high dose of progesterone. So because oral micronized progesterone goes to the liver, it is 5-alpha reduced a lot, which is why we have people take it in the evening. Basically, just think about like the effects of progesterone on the brain are augmented if you take it orally, which can be good and can be bad. For some people, it gives them great sleep if they take a low dose. But for a lot of people, especially if they're taking, pregnancy type doses, because progesterone increases quite a bit in first trimester, then yeah, a lot of women feel terrible on progesterone. It is still not the most common cause of pregnancy loss. The most common causes of pregnancy loss, kind of like preventable ones, well, the most common cause is aneuploidy. So most likely abnormal levels of chromosomes, and those are not preventable, if you will. But the most common cause of preventable is what we used to call subclinical hypothyroidism. We now call it euthyroid 6 syndrome. In the first trimester of pregnancy, the requirement for thyroid hormone goes up by 30%.
Okay.
So if there is someone who is borderline low on either free T4 or free T3, or their TSH has looked suspect, or they've had high reverse T3, I would very aggressively check and replace thyroid hormones. And the other cause is GI or GU infections or UTIs. So any sort of bacteria that gets in or near the urethral or, basically bladder will irritate things. And that's also a risk of pregnancy loss. So those things I'm extremely aggressive checking. It is reasonable to supplement progesterone in some cases, but a shared decision making is essential with the provider, and they should talk to you about the risks that I mentioned with pregnancy. It's not just how you feel. Most of the long-term risks are theoretic, but yeah, the provider that is prescribing the progesterone should be able to comprehensively describe both the well-known and the not well-characterized risks and benefits of progesterone in pregnancy.
You highlighted some new hormones that we haven't talked about, that is thyroid hormone, T3, T4, free T3. How are these important when it comes to a proper response to a calorie deficit, especially because sometimes we see clients that they truly do their best. They are very compliant. They are doing everything they can. And they just seems to have a very difficult time losing weight. Would be there a space to look into reverse T3 and the correlation of chronic dieting? Is there anything that we could talk about that would be worth considering, or maybe just investigating a little bit further when you see these issues of resistance for weight loss, even if there's good compliance?
Yeah, so thyroid in the context of weight loss and fat loss is super interesting. So most in the fitness community are aware that nutrient status is very important for thyroid hormone function. Selenium, boron, enough iodine, but not too much iodine. Enough biotin, but definitely not too much biotin. But there's a lot of ways to basically nutriently turn up or turn down the production of thyroid hormone. Now, if there isn't enough TSH, or if there's an issue with the feedback loop, then yeah, a lot of times that does lead to what I mentioned earlier, which is the euthyroid sick syndrome. It's basically you're not clinically hypothyroid to where you don't have to start thyroid hormones, but often if you're symptomatic, then you presume that in a lot of cells of the body that you have not optimal levels of thyroid hormone, which is causing the symptoms. And if your reverse T3 is very high, then it is likely causing even worse symptoms of that. However, it's not really going to affect your weight. So it's more of a drop in the bucket when it comes to weight loss. Yeah, there's a lot of correlation studies. The group of people, I've done a podcast just on this too. Those darn people who eat whatever they want and never try to exercise, and they always stay the same weight. Yes, almost all of them do have optimal thyroid hormone status, but the other characteristic of those people is they move way more than they realize, way more than the average person, and they eat way less than even they realize. So it more has to do with hunger signaling and the emotional feedback system when it comes to eating, which is always a very difficult conversation. But so yeah, thyroid hormone for weight loss, just a drop in the bucket. For body composition, thyroid hormone is huge, especially when it comes to visceral adiposity. So let's say someone gets a DEXA scan and they have 7 pounds of visceral adipose. If they're anywhere near euthyroid sick syndrome or subclinical hypothyroidism, same thing, I will very likely talk to them about the risks of thyroid hormone, palpitations, arrhythmias, and start them on thyroid. And the new treatment for fatty liver disease is the thyroid hormone agonist is very promising as well. So it does affect where adipose is built up.
Would you say that then, if we have someone who has been truly doing their best to get the weight off, and they feel like a good portion of the body fat is accumulated in the visceral area, would you prescribe, even maybe let's say they're not necessarily subclinically hypothyroid or this relatively normal thyroid function, would you still consider putting them on thyroid hormone replacement, even if it's a small dose? Or you would go into other options like GLP-1, like now that we are seeing that more often, or any other sort of medication that maybe helps reduce appetite or increase your metabolic rate?
Yeah, I would look at other options. And even if they think they're having symptoms, if all of the thyroid labs looked mid-normal, perfectly fine, not near borderline, a lot of times it's the state of their neurotransmitters. It's their dopaminergic tone throughout the day. Maybe their prolactin is high, which there's kind of niche reasons for that. Maybe their sleep is off. Maybe they feel sluggish and tired and they feel low thyroid, but maybe they have a touch of sleep apnea. That can certainly happen. A lot of the new sleep meds, like the DORAs, the dual orexin receptor antagonists, a lot of those, compared to placebo, people tend to lose weight when they start them, which is kind of odd for a sleep med. But, if you sleep better, generally you lose weight as well. But a lot of sleep meds are tranquilizers. In this case, orexin, which can be blocked, is, I call it the hangry hormone. You're hungry, you're angry, and you're awake. So it actually works particularly well in people that are cutting down for a show. So because, they're hungry and angry and awake, they're starving. So it works great for those individuals. But
Which one is that?
the DORAs, dual orexin receptor antagonists, I know they've just kind of recently come into vogue, but we've had them for quite some time. Somra works primarily just on one orexin receptor, and then Quvivic and Dayvigo work on two orexin receptors. So there's new, exciting, like very specific classes of sleep meds that a lot of people who are on like sleep meds with a lot more side effects are a good candidate to switch to. Yeah, past that, and they work best if you take them for, like at least a week at a time. So some people will take it for a month, some people 2 months. I try to keep people off chronic meds of any type, but yeah, that would be another option instead of thyroid hormone. And then anything to help support neurotransmitter function. Lifestyle first, medications past that would be good options. If they're not insulin resistant and they don't have metabolic syndrome, sometimes in the long run, and they don't have, diabetes or morbid obesity, often in the long run, it's actually easier to not jump straight to a GLP-1, which GLP-1s are still some of my favorite meds. But, if you're thinking about 1 year from now, 2 years from now, 3 years from now, assuming you don't want to be on a GLP-1 for a lifetime, which you probably don't, if you don't have a comorbidity that necessitates it, then often you're better off looking at other strategies. Now, if you have prediabetes or insulin resistance or greater than about 40% body fat as a female, 30% as a male, more or less, is, rough rule of thumb, then often you are a good GLP-1 candidate.
Let's talk about GLP-1. Would you be inclined to advocate for the use of GLP-1 in patients that are not necessarily obese, and or maybe just they are just having issues losing weight, they're overweight, but they're not necessarily obese?
Generally, no. And again, the answer is always it depends. So I was going to say definitely not if they're not overweight. But, if they're a new type 1.5 diabetic, almost for sure, I'd say that the benefits of a GLP-1 right now, for example, potentially saving you from being on insulin for the rest of your life, the benefits of that would outweigh the downsides. But for your average individual who's overweight, not obese, I'll go by body fat percentage. I think we should completely get rid of BMI and maybe even scales. I don't know. I used to think that people that were like smashing scales and whatnot, I used to say, oh, well, that's ridiculous. You're just trying to be dramatic. But I am very frequently very angry at, I try to talk about body composition and fat loss, and the scale makes me angry, not just because of like patients that kind of hyperfixate on it, but friends and family that I love very much. And, like it can be harmful, but it's a great tool. Like everything is a tool. A hammer is a tool if you use it correctly, but you can also use it very incorrectly. So there's the balance on that. But yeah, let's say there's a male between 20 and 25% body fat and a female from, 30 to 35% body fat. Unless they have prediabetes, very unlikely to utilize a GLP-1. There's a lot of other options that are better. And if anything, that's just going to lead them to a propensity for rebound.
When people are using GLP-1, would you say that they are meant to use it for the rest of their life? What happens if they stop using it? Because there's a big, huge fear around, if I stop, then I will rebound, like you mentioned. But what happens if beyond just using this medication to lose the weight that you need to lose and improve your insulin sensitivity, if you have, like, let's say, a certain degree of insulin resistance, if you learn the skills of healthy habits and exercise and training and eating mindfully and doing all the things that you need to do when you're not in any medication, you're just trying to do the best you can to lose weight. Even if you did stop the medication, the GLP-1, would you still be more propense to rebound? Or is there a way to get off the medication and still maintain the weight off you lost?
Yeah, I love this question. It's highly debated. And interestingly, if you look at the studies, for example, if you look at I think it's one of them is called a STEP trial, but if you look at one of the main studies for Wegovy, which is a brand name semaglutide, or if you look at the studies for Zepbound, which is a brand name, or Mounjaro, which is brand name tirzepatide, you have very high rates of rebound so they had two groups of people. In both these studies, they kept both groups on it for about 1 year, and then they gave one group placebo for a year and one group the medication. So the group that continued the medication maintained the weight loss in almost every single case. About 80% of the time, the group that was given placebo regained the weight back. Many of them more, but on average, they almost regained all the way back to normal. But if you look at the studies from, I guess out in the real world, not at clinical trial sites, where, a lot of these places are obesity medicine clinics, they have multidisciplinary teams, they have dietitians, they have, they're getting trained to do exercise. So I think every clinic should at least train people to do basic exercises. That's why we have equipment here, even in our relatively small clinic. But when you do that, about 50% that were taken off do not regain the weight. So that's a much better rate. And if you compare that to people not on GLP-1s, even people who are successful losing weight through lifestyle modification without pharmacotherapy, at least 90% of those people regain the weight. Even higher if you look at 5-year rates. But if you're just looking 1 year to 1 year, like some people would take that as, a negative. But what did the small percentage of people that kept the weight off, what did they have in common? A new movement pastime to last a lifetime. Didn't have to be lifting weights in the gym. They exercise very often, and dietary changes. So if you have those two things in common, then yes, you are very likely to keep the weight off as you take the GLP-1 off. However, it's crutches. So you'll have to relearn to walk as you take the GLP-1 off. It's harder to learn lifestyle interventions if you're on a GLP-1. It's like a crane that takes you out of the quicksand and places you on the other side. You haven't really learned how to dig yourself out with like shovels and other smaller tools like supplements or Apolline or whatever else you're using. But when you take it off, especially if you're on a high dose GLP-1, you want to come down very slowly.
You mentioned something very interesting that is about how it is a crutch to lose weight, especially for those that are struggling or have any particular issue with their metabolic rate or the insulin resistance. But what is the actual effect on your brain or at the level of your orexigenic hormones?
Mm-hmm.
of this medication to be so successfully potent, that has gained so much more attention and it's been more successful than any other weight loss medication, what is the main effect at the level of the brain beyond what it's doing at the level of your gut, or whether it's at the level of the gut that is driving all these responses? What is it about this medication that is so successful and so potent at reducing appetite?
And regardless of if it's a single incretin or a dual incretin, so tirzepatide's a dual incretin, not that those terms matter, it's kind of too jargony, but the brain is just one of the mechanisms. It also works in the liver very strongly, in the intestine itself, small intestine, large intestine, and stomach. And it also works in the pancreas. But in the brain, it affects all areas of the limbic system. It is going to affect pretty significantly cravings in the hypothalamus, but it also works in the amygdala, I believe also the hippocampus, and like kisspeptin related neurons that produce kisspeptin. And it'll affect leptin status as well, whether it's primary or secondary, we don't really know. But we do know that it directly affects cravings outside of its effects in the gut, the liver, and the pancreas. This is dose dependent. So when you withdraw it all of a sudden, then those are likely to rebound. And you combine that with much faster gut transit that facilitates you to kind of like perseverate and hyper binge on those cravings.
So would you say that there is any meaningful dose that you would say this is the most successful dose that is recommended or used by patients? Because there are also like secondary effects. So I have a client that she's on Saxenda, but I'm not sure if that would be considered a similar one, but she was recommended to use it on a regular basis. She has to inject it daily, but she was unable to tolerate like 1.2 or a bit more than that. And she was like always sick. And like there were so many side effects that she was actually bedridden, super sick and super lethargic.
Yep.
And then my sort of like thinking thread for her and talking through ideas to make her feel better was, well, let's reduce the dose to half. Or maybe, is it too dangerous, or is it a bad advice to take it every second day instead of like every day? Or once you start this medication, you gotta take it regularly every day?
Yeah, those are great questions. And by the time this is posted, I'll probably have this post up. I have the tier list of adjuncts for your GLP-1. So like how to be less sick, get more muscle, lose less fat, and get off easier. So different interventions. And near the top of that list is, well, also near the top of that list is using a strategy other than a GLP-1. But there's kind of two categories of people. One category, they need it for cardiovascular protection. They're like extremely high risk of heart attack or stroke if they didn't take it. They have type 2 diabetes or type 1.5 and sometimes type 1 diabetes. There's actually a decent amount of studies on pure type 1 diabetics, usually early on, but I do have patients that are pure type 1s that are on a GLP-1. And then people with morbid obesity. So if they're in that category, then generally the clinical doses are ideal. So usually that's more than about 1 mg of semaglutide, liraglutide, which I actually also like. The downside is you really do need to inject that every day if you like the more dysregulated your hunger, the more important it is to inject every day. In general, some patients that I have on semaglutide or tirzepatide, I actually have them inject twice a week, even though the normal schedule is once a week. I have them inject half of what they would normally be on, but 2 days a week. With liraglutide, your suggestion of 0.6 a day instead of 1.2 or whatever she was on is quite good. But liraglutide, whether it's Saxenda or Victoza, is in general a decent amount weaker than the other two. Improving gut transit can help to make sure that the peristalsis continues going the right way. looking at her gallbladder function and make sure that she's not building up some big gallstone that's causing a lot of the pain and symptoms and nausea. That's also another good thing to do. See if she has more symptoms after fatty meals, for example. And then considering a switch to a different GLP-1, like Wegovy, where she could do a very low dose twice a week. In general, so side effect wise and dose wise, if you tolerate a high enough dose of semaglutide, it has all the same risks and benefits of tirzepatide. Tirzepatide just goes much higher. So I'd say my average patient who is overweight, maybe borderline obese, but perhaps they could get by with a GLP-1, I go no higher than 1 mg of semaglutide per week. Usually, like often just 0.25, and often the lowest dose of liraglutide, which is 0.6. I've used that every day in patients as well with good success. With tirzepatide, most of my patients are just on 2.5, which is the starting dose. And past that, 5 mgs. I do have a couple patients on slightly higher doses, but I'd say almost all my patients on tirzepatide are on one of the first 2 doses.
If you have a specific target for the day, let's say 1.2 or 0.6 or whatever, can you play with the timing? Does it matter the timing when you inject it? Does it matter whether you do like half and half in the same day if you're having some like a huge amount of symptoms? Does it matter whether you take maybe every second day instead of every day? Like how this frequency of injections and the doses distributed throughout the same day have an impact, or whether that would be too risky or impact your blood sugar fluctuations or get you, I don't know, hypoglycemic. Is there any sort of risk on doing these sort of like small variations of doing injections exactly the same time every single day at the same dose? Or could you make some sort of smart tweaks in the dosing?
Yeah. So I do frequently have significant changes in dosing. Liraglutide, by the way, Saxenda is generic in the United States now. I don't know if I don't know if they're like on shelves yet, but it is generic now. So it's brand name patent. It ran out. Actually, Victoza, not Saxenda, but again, it's the same thing. So there's generic liraglutide. But yeah, in general, you'll have better efficacy. So it'll work better with more frequent injections. The theoretical downside to that is if you do give people a break from it, then perhaps it decreases the risk of something like gastroparesis, and it does seem to decrease the risk of ileus. So it's kind of standard practice for surgeons to have patients stop their GLP-1, regardless of which one it is, a couple weeks before surgery, because they don't want the intestines to be, paralyzed, which is kind of what we call ileus or post-operative ileus, because both GLP-1s and surgery have that risk. So it is possible that if you had a patient do every other day liraglutide, you'd still have some success, maybe 70 to 80% of the efficacy, but perhaps they would have a bit better movement in the gut and the hepatobiliary pancreatic ducts. Now, that's all out of theory, but it is a reasonable thing to do with patients. And I do have some patient, I don't think I have a patient on every other day liraglutide, but I do have patients on every 10-day GLP-1 regimens instead of every 7-day.
Okay. I think it's more just thinking about the different strategies that a patient can still use it, but managing the adverse effects of those medications, especially if they are very sensitive to just being nauseated all the time or not being able to even eat because they just can't keep things down. So in this case, do you feel like the recommendation of maybe just having the dose in the morning or with food, does it make any difference whether you have it with or without food, or near close to that? Or just breaking down the dose, let's say you have a 1.2, and then can you have half in the morning and half at night, or doesn't make any difference?
You can have half at morning and half at night. A lot of patients would probably have adherence risk with that. But yeah, generally I have patients inject their GLP-1 with a meal.
Okay. Awesome. All right. So I do have way more questions that I thought I would have, but I am honoring your time and I want to make sure we can have a proper discussion on another quite a big range of topics. How do you feel about scheduling potentially another one soon-ish, and
I would love
go
to.
through all the things that are a bit more related to not just hormones, but supplements, medications, medication interaction, and potentially other areas that I would like to touch on, if is that something that you could possibly do?
That would be wonderful. And we would also love to have you on our podcast where
Oh,
I asked you.
oh, that would be amazing. I would love that. Let me know. Just send me a message with some potential dates and we can figure that out.
Perfect. Likewise. Thank you.
Well, Kyle, was such a great time to see you and have a very interesting discussion about everything we covered today, mostly GLP-1, but also hormones and thyroid and female hormones. I think that was like a very good chunk of information for people to digest. Where can people find you?
Yeah, my main hub is on Instagram, Kyle Gillett MD. I do post all of my recommended lab panels, even if you take them to like whatever other doctor or service. It has all the biomarkers listed for males and females on GilletteHealth.com. And I guess I see patients and have a podcast too. So, but yeah, info would be on GilletteHealth.com and Gillette Health on all platforms, YouTube, Spotify, etc. We have podcasts, I guess, various topics. Could be anything. Could be anything from herpes virus titers to body composition.
That's awesome. Kyle, I appreciate you and I'll talk to you very soon.
Thank you. My pleasure.
Bye.